Welcome to this case-based challenges presentation regarding histology, molecular testing and treatment decisions in non-small cell lung cancer. My name is Dr. Mark Sosinski from the University of Pittsburgh. This first slide, which you can pause on, summarizes the disclaimer in disclosures of unlabeled use. My disclosures regarding conflicts of interest are listed on this slide. I do have a relationship with Celgene Corporation and Genentech with regard to Speakers Bureau, and the companies listed on the slide are companies that I have contracted research agreements with through my institution, the University of Pittsburgh. Today's agenda takes us through 3 case challenge presentations, the first on tissue sampling and molecular testing, the second on treatment decisions, and the third on emerging therapies in non-small cell lung cancer. Our learning objectives today really center around the importance of obtaining adequate tissue samples and defining appropriate non-small cell lung cancer therapy, implementing molecular testing strategies according to current guidelines, evaluating therapeutic strategies with regard to individual patient subtypes and how they impact our therapeutic thinking and approach, integrate evidence-based clinical data and treatment guidelines into the selection of therapeutic options, assess the latest clinical trial data on some upcoming investigational therapeutic options, and provide appropriate care and counsel for patients with this disease. So let's move on and talk about lung cancer facts and figures. I think most of the audience realizes that this disease is the most common cause of cancer-related mortality in the United States, accounting for more deaths combined than breast, prostate, and colorectal cancer. The disease is very heterogeneous from a histologic and molecular point of view. Historically, we've not practiced screening, so we have an unfavorable stage distribution at the time of diagnosis. Smoking remains the major risk factor, and this is largely a disease of the elderly patients with a median age of 70. 10 to 15% of lung cancer diagnoses are seen in true never smokers, and historically this has been a disease shrouded by therapeutic nihilism. Non-small cell really accounts for the vast majority of cases. The figure to the right shows the extent of disease at the time of diagnosis, comparing localized, regional, and distant. You see most of the patients have distant disease at the time of diagnosis. Now, hopefully, screening may reduce or change the stage distribution. However, that remains to be seen. This slide summarizes the first-line considerations that I make in my deliberations in patients with good performance status. How well established is the histologic diagnosis? Do we have a good sense of whether this is squamous or adenocarcinoma, the 2 major subgroups? Is the tissue available for special studies? Certainly EGFR and ALK testing are part of our current guidelines, but there are ROS1 and others to consider. What is the optimal care of chemotherapy for this patient? Is there a role for selected targeted therapies, either anti-angiogenic or anti-EGFR? Who are the patients that you identified that you're going to pursue genotypically driven therapy rather than standard cytotoxic chemotherapy? And then a number of factors with regard to the patient: age, performance status, end organ function, comorbidities, and since this is a treatable, although not curable disease, what are the patient's preferences in terms of how they want to be treated and how aggressive and what side effects are concerning most to that particular patient. The next slide summarizes as I mentioned, the 2 major histologic subtypes that we have. Adenocarcinoma, the most common, and you see in the photo this is often glandular mucin positive. I do list on this slide the cytokeratin stains as well as TTF1 positivity. Most of the patients with adenocarcinoma are TTF1 positive, and that is probably the single best marker for adenocarcinoma histology. On the bottom are a couple of photomicrographs of squamous cell carcinoma. This is typically characterized by cellular keratinization, intracellular bridges, and keratin pearl formation. Again, I've listed the cytokeratins on the bottom, and this is typically cytokeratin 7 and 20 negative, a TTF1 negative, but there are several markers specifically that help confirm the diagnosis of squamous cell, P63 and P40, as well as cytokeratin 5 and 6. Now, the bulk of the heavy lifting, if you will, is done by morphology, and you see in the World Health Organization classification, it really takes into account the morphology and not necessarily the special stains. I would encourage you, all centers, to minimize the number of special stains and probably proceed with one good marker for adenocarcinoma, TTF1, and one for squamous cell. At our center, we use P40. Now, this slide just summarizes why we care about histology. Molecular testing guidelines tell us to routinely test in EGFR and ALK in any patient with adenocarcinoma. There are therapeutic considerations. Pemetrexed is indicated only in non-squamous histologies, and bevacizumab is contraindicated in squamous histology due to the risk of pulmonary hemorrhage. Also, prognosis. In general, patients with non-squam do better than those with squamous histology. So those are the major reasons why medical oncologists care about histology. Now, the next slide moves us beyond histology, and we know that there are several very relevant genetic alterations. These are typically in adenocarcinoma. We've mentioned EGFR and ALK, but there are others listed on the slide. And as I mentioned on one of the introductory slides, this is a very complex disease from a molecular point of view. Some of these are actionable, and we have FDA-approved agents for entities such as EGFR and ALK. But for instance, ROS1, although not FDA-approved, certainly crizotinib has activity. In squamous carcinoma, even though there are a number of defined molecular alterations, we don't yet know that these are always driver events, and we don't yet know that targeting them really has therapeutic benefit, although there certainly have been anecdotal cases with a number of these particular markers. The next slide summarizes the 2013 CAP guidelines for testing. Again, as I previously mentioned, any patient with a component of adenocarcinoma should be tested for EGFR and ALK. At the time of diagnosis, you have to make sure you have adequate specimens. Testing should be done concurrently within a couple of weeks. And I do think it is a now standard of care that retesting is important at the time of disease progression, particularly in EGFR mutant disease. So let's move on to case one. As shown on this slide, this is a 68-year-old gentleman who develops a cough and a 5-pound weight loss. He smoked for 20 years but quit at age 42, so a couple of decades ago. He has no significant other comorbidities, and his ECOG performance status is 1. Because of his cough, a chest radiograph is performed showing a 4-centimeter mass in the right upper lobe, and there are multiple bilateral pulmonary nodules. The CT confirms this and also shows a 3-centimeter left adrenal mass, as well as 3 small liver lesions. His brain MRI is negative. He is referred to a pulmonologist who performs a bronch, and the wash specimen shows adenocarcinoma. The tissue sample is scant, and your pathologist tells you that the specimen is not adequate for molecular testing. So let's talk about the traditional non-small cell analysis. The tissue is obtained, sent to the pathologist. There's an analysis of tumor morphology leading to a diagnosis. And historically, we have asked our pathologists to distinguish between small cell and non-small cell. However, since the advent of bevacizumab, we've asked them to make a further distinction between squamous and non-squamous disease, most of which is adenocarcinoma. And on this particular slide, you see a very robust biopsy. This looks like a core biopsy that was obtained, and the majority of this sample is tumor cells. The biopsy specimen matters, the size of the specimen as shown here, the specific subtype, the importance of accurate interpretation of pathology reports is vital in the management of this. And as mentioned on the previous slide, in every adenocarcinoma patient, we should be performing EGFR and ALK testing, which requires a certain amount of tissue to accomplish that. Issues to consider in approaching patients diagnostically: what is the best tissue to sample? The amount of tissue, multiple FNAs that are cellular can be made into a cell block. And so sometimes that may be optimal. I think this is a situation where one size does not fit all patients. So our colleagues that are doing the diagnostic biopsies need to be well versed in assessing these sorts of things. In my case that I presented initially, bronchoscopy led to a diagnosis of adenocarcinoma. However, there was inadequate tissue to do molecular testing, and I think it would be important in that particular case to think about this. We also have the validity of various assays that are being performed, the type of assays, whether you're looking at single genes. Are you going to just test for EGFR and EML4 ALK, or are you going to do multiplex testing and test for a number of different entities? I think it's safe to say that, as I mentioned, this needs to really be a multidisciplinary approach. At every center, the medical oncologist should be very familiar with the interventional radiologist, all pulmonologists, all thoracic surgeons, and really have an approach that really allows one procedure to obtain an adequate amount of tissue, to determine histology, and to have enough tissue material for molecular testing. This next slide just summarizes some of the issues or further issues about tissue sampling. You certainly can do diagnostic IHC staining and mutational assays on small biopsies and cytologies that yield adequate tissue. We've reinforced the concept several times already that all adenocarcinomas should be tested. Other histology is clinically indicated, and I base that mostly on smoking status. We should get this done quickly. The priority should be to establish a diagnosis and then to obtain tissue for the two actionable EGFR and ALK entities. KRAS is listed on this slide. KRAS is listed because it's the most common molecular abnormality we see in adenocarcinoma. And largely, if you have a KRAS mutation, I think for the most part, you can probably stop testing for other entities because these are largely mutually exclusive. Really, the goal here is to identify the proper histology with as few stains as possible and to conserve tissue and not use it up using multiple immunohistochemical stains. With regard to how much material is needed, there needs to be a certain tumor cellularity for Sanger sequencing and maybe a little less for more sensitive methods. All cell blocks should be interpreted as adequate for diagnosis by a pathologist at the time that they're obtained, so you can make sure that there's a sufficient quantity and quality of DNA for your mutational analysis. The absolute numbers or guidelines are given in this particular slide in terms of median DNA yield, median tumor cell count, so on and so forth. Again, the bottom part of this is prioritizing tissue for mutation testing, not wasting the sample with unneeded IHC stains, and to try to focus your immunohistochemical stains to help you distinguish the diagnosis between adeno and squamous. And I would make the point that not every case needs immunohistochemical staining. Sometimes when pathologists that are experienced here, they can certainly make a very confident diagnosis of, for instance, squamous cell just on histopathology. Now, one of the issues summarized on the next slide is how much do you test? Do you do single gene assays and looking specifically, and again, this would be for entities such as EGFR, ALK, and KRAS, or do you do testing on a much larger scale? A multiplexed assay is shown here. These may take a little bit longer. They test many genes and so on and so forth, and sometimes they find alterations that potentially could be helpful, however, often find alterations in which the path forward is not entirely clear or may identify patients for a particular clinical trial of some sort. So I think we have to kind of factor these in when we decide what's the best way to approach these patients with regard to the amount of testing that's done. Again, the next slide summarizes a theme we've seen on a previous slide, but this summarizes the lung cancer mutation consortium data published in JAMA last year. This showed that in the majority of lung adenocarcinomas, that there was a potentially targetable mutation or translocation noted in this, and you can see that 2/3 of patients had an entity that could be targeted either with an FDA-approved agent or with an investigational agent for that particular target. So we have transitioned over the past decade into thinking about this far beyond a histopathologic diagnosis. I think the next step is the molecular subset of lung adenocarcinoma. And again, this is a rather complex disease as shown on this particular slide. And the next slide shows the importance of why we test. This is looking at, again, the LCMC data showing survival curves based upon the presence of a target in the patient receiving a targeted therapy. And what we see in the upper right-hand corner on this slide is that this superior survival curve was really driven by EGFR mutants and ALK translocated patients that are treated with the appropriate targeted agent. And this is a very elegant slide and really reinforces the concept of testing. And if you identify one of these genetic alterations, it is critically important to get the patient the appropriate therapy for the driver mutation that you may identify in this particular setting. Now, this slide summarizes other mutations beyond EGFR and ALK, and we've hinted a little bit to that, but I've mentioned ROS1. There are BRAF mutations, MET amplification, where we have data suggesting that targeted agents can induce responses, and a number of other alterations shown on this particular slide where there may be therapies either in clinical development or perhaps drugs that are FDA approved, perhaps not in the indication of lung cancer, but in other indications where one may consider use of these agents off-label in these particular subsets of patients. So again, this gets back to how far are you going to extend the tissue testing in your individual patients, and one can look at a number of genetic alterations beyond EGFR and ALK. Well, let's slip into case challenge number 2. This really revolves around treatment decisions. I've summarized on this slide the standard of care in patients without identifiable driver mutations. And again, this is based on histology. In the non-squamous population, we typically choose pemetrexed or taxane-based doublets. Bevacizumab is appropriate in selected patients, although there are certainly many contraindications to bevacizumab. In my practice, I administer 4 cycles, maybe occasionally 6, but that's not very usual for me. And after 4 cycles, there are issues of maintenance that one considers at that time. Now, in squamous, our choices largely are related to taxane or gemcitabine-based doublets. I, again, use 4 cycles. There are fewer maintenance considerations, but there are some. One could often consider continuation maintenance with gemcitabine. Switch maintenance with the drugs like docetaxel or erlotinib are certainly evidence-based options. This next slide summarizes the 3 major trials exploring the use of bevacizumab in the first-line setting. These are the key results. You can see the ECOG 4599 is really the landmark trial, and then the AVAIL trial as well as the Japanese trial. Now, all of these trials showed a significant improvement in overall response rate in favor of bevacizumab. All of them showed a significant improvement in progression-free survival in favor of bevacizumab. The only trial that was powered for overall survival was ECOG 4599, which did show a significant benefit in overall survival. The other 2 were not powered for survival and actually were negative for survival. So I And actually, the other important point here is the primary endpoint of AVAIL in the Japanese trial was progression-free survival. So in a sense, we have 3 positive phase 3 trials for the use of bevacizumab in selected patients, and that's why I had it on my one of the previous slides. Now, one of the more influential trials over the past decade or so has been the Scagliotti trial, exploring cisplatin pemetrexed relative to cisplatin gemcitabine. This obviously is an important trial that led to the FDA indication for cisplatin pemetrexed. This was a non-inferiority trial, so it was a very large trial, 1,725 patients. And you can see, looking at the Kaplan-Meier curves on the bottom part of the slide, that this was, in a sense, actually was a positive trial. This met its non-inferiority endpoint. You can see these curves are essentially superimposable. The median survivals are identical at 10.3 months, and it met its statistical endpoint of non-inferiority. Now, during the conduct of this trial, it was becoming apparent that perhaps there may be preferential activity of the multi-targeted antifolate pemetrexed based on the observation of differential expression of thymidylate synthase between the histologies of non-squamous and squamous, with squamous having higher expression and therefore perhaps more difficult to inhibit. And you can see this prospective analysis of survival by squamous really was very influential in the FDA approval process for this drug. You can see to the right, which I think is the important lesson here, actually it looked as if gemcitabine was superior to pemetrexed, whereas on the left in the non-squamous, pemetrexed seemed to be superior to cisplatin gemcitabine. And this was influential in the FDA indication, where they specifically said that cisplatin pemetrexed is indicated only in non-squamous histology patients. Now, presenting the bevacizumab data and then the pemetrexed data, one of the next logical extensions is pemetrexed-based therapy better in combination with bevacizumab relative to the ECOG 4599 regimen? And you can see the Point Break trial actually addressed that. This was a open-label randomized phase 3 trial trying to define the superiority of pemetrexed over paclitaxel. Standard doses in these regimens, you can see there was an induction phase of 4 cycles shown here, and then a maintenance phase. So there were really 2 variables in this trial: the pemetrexed versus paclitaxel in the induction phase, and then in the maintenance phase, a 2-drug maintenance strategy, both PEM and bevacizumab versus bevacizumab alone. This was first-line patients, good performance status, stable treated brain mets were allowed. You can see the stratification factors on the bottom part of this, and the primary endpoint of this trial was overall survival. Looking at the primary endpoint on the right-hand side of this slide, you can see that this was a completely negative trial. The hazard ratio was 1.0. The curves are superimposable. There was obviously no evidence of superiority of pemetrexed, and I would argue that both pemetrexed and paclitaxel combined with carbo and bev are very good regimens for the treatment of this disease. Additionally, when one looks at the table over the left-hand curve, which is the PFS curve, the overall response rates were identical at 34 and 33%. There was a statistically significant benefit in progression-free survival, although I often wonder how clinically impressive that is. It was a difference of about 2 weeks, hazard ratio of 0.83, and a significant p-value of 0.012. Is that because of the 2-drug maintenance strategy? Not clear. I think one has to wonder about that. So this slide summarizes the standard of care in the non-squamous population. Genotyping, again, as we mentioned several times here, is the standard of care. Bevacizumab is a choice in selected patients. The optimal choice of platinum doublets is typically carbo plus a taxane or pemetrexed, optimal duration 4 cycles. Maintenance is an option, but certainly not a mandate. I think it's very commonly practiced with two drugs, bevacizumab and pemetrexed, but certainly not a mandate. The major question in my mind is platinum plus pemetrexed as good as platinum plus either PEM or paclitaxel plus bevacizumab in a bevacizumab eligible patient? And we really have no data to support that at this particular time. And obviously it's important to discuss this trial because I think this was probably one of the most, if not the most important trial in lung cancer over the past decade. And the reason I say that is because it really transformed lung cancer into a genotypic disease. There was evidence early on, a decade or so ago, that EGFR TKIs such as gefitinib, erlotinib, and now afatinib worked in a certain phenotype. And that phenotype was never smokers, Asians more than Caucasians, adeno more than squamous, and women more often than men. And so one of the impetus at that time was to do a study like this where you would go to Asian countries and enroll patients with adenocarcinoma histology that were never light smokers and make a comparison of a TKI, in this case gefitinib versus carboplatin and paclitaxel. Now, obviously, a decade or so ago, we realized that those phenotypic markers really identified patients at high likelihood of having EGFR mutations where EGFR TKIs are extremely active. In the IPAS trial, the primary endpoint was progression-free survival, looking for non-inferiority. So that led to a large number of patients, over 1,200 patients here. You can see the secondary endpoints on the slide. One of the correlative endpoints was looking at the impact of having a mutation or not having a mutation in this particular setting. Now, when you impose those eligibility criteria, I will tell you that of the 1,200 patients, 79% of them were women. 94% of these patients were true never smokers. And 60% of them had an EGFR mutation. So 60% mutant positive, 40% mutant negative. This slide looks at the primary endpoint of progression-free survival, but divides the population based upon EGFR mutation status. Now, before we look at this, I will remind you that this trial met its non-inferiority endpoint as an entire group. So if you take all 1,200 patients, the progression-free survival actually was superior with gefitinib relative to carboplatin. Remember, I said it was designed as a non-inferiority trial, but actually gefitinib was superior to carbotaxol with regard to progression-free survival. But it was only due to the following observation. If you look to the left, where the EGFR mutation positive patients are, remember 60% of the patients had an EGFR sensitizing mutation. And you see in this case, the hazard ratio for gefitinib relative to carboplatin and paclitaxel was 0.48. So gefitinib was much more active with regard to improving progression-free survival relative to carboplatin and paclitaxel. However, I think the important lesson of the IPAS trial is shown to the right in the EGFR mutation negative patients. Remember, prior to this trial, if an Asian never smoking female with adenocarcinoma walked into any medical oncologist office, they would get treated with an EGFR TKI based on the phenotype. But if that patient didn't have an EGFR mutation, you see the survival curve for gefitinib is far inferior to that of chemotherapy. You see the hazard ratio in favor of carboplatin, almost threefold more active is chemotherapy than is gefitinib. The treatment by subgroup interaction test was highly statistically significant, so the status of your EGFR mutation relative to what type of treatment you received was highly statistically significant. And I think this is the importance of the IPAS trial. It was transformative, making non-small cell lung cancer a genotypic disease. It was no longer acceptable to look at a phenotype and make a treatment decision. You had to know the genotype of the patient. Shown on this slide is the response rates. And again, I will just highlight to the right the mutation negative patients where the response rate to gefitinib was 1%. and chemotherapy was about 25%. Now, if you look to the left, you see the response rate to gefitinib was 70%, but even the response rate to carboplatin paclitaxel was about 47%, so much better response rate in EGFR mutation positive versus negative with regard to the activity of carboplatin paclitaxel. So this is important information because let's say you have a very sick patient and you're waiting for the EGFR mutation and you feel like you have to start therapy. It's okay to start carboplatin paclitaxel or some other platinum-based doublet because it's good therapy for these patients. And you shouldn't hold back therapy if a patient needs treatment. The one mistake would be if you don't know the EGFR mutation, you should not treat with an EGFR TKI because it's far inferior to combination chemotherapy, and that's an important teaching point of the IPASS trial. Now, this next slide, it always amazes me that in a decade or so we completed all of these randomized phase 3 trials looking at gefitinib, erlotinib, and afatinib in EGFR mutant patients in the first-line setting, comparing it to a number of different chemotherapeutic doublets. And in every one of these trials, the EGFR TKI, so oral therapy won. The response rates are 2 to 3-fold higher. The PFS is 1.5 to 2 times higher. The one fly in the ointment was we had never demonstrated a survival advantage, and I think as is noted on the slide, it probably is likely due to a crossover effect. Obviously, most physicians who are treating patients in these trials, the mutation status was known of the patient. They were positive for a sensitizing mutation. And when they progressed on chemotherapy, they crossed over to an EGFR TKI. And, you know, I think the data suggests that whether you get an EGFR TKI first or second line, you probably don't compromise survival. However, I do think it's vitally important to test and administer EGFR TKIs as first-line therapy because you can't always guarantee that the patient's going to make it to second line, and you certainly wouldn't want to withhold the most effective therapy for these sorts of patients. Now, you noticed on the previous slide that the last couple of trials were afatinib-based, LUX-Lung-3 and LUX-Lung-6. We do have published recently a combined analysis of these two trials. The two trials were very similar in the sense that they randomized patients to afatinib and or versus chemotherapy. The chemotherapy differed. In LUX-Lung-3 it was cisplatin plus pemetrexed, and in LUX-Lung-6 it was cisplatin gemcitabine. The patients here were stratified by EGFR mutation type as well as race as shown on the slide. When you look at the combined overall survival analysis of the common mutations, and this would be limiting the analysis to either exon 19 or exon 21 sensitizing mutations, you see a demonstration of a survival advantage with a hazard ratio of 0.81 and a p-value of 0.03. So finally, we do have evidence that administering afatinib as first-line treatment rather than chemotherapy does have a survival advantage. And I think, you know, we have to deal with the crossover effect and all these sorts of things, but I do think that based on response and PFS data, this is clearly better therapy. And the lack of proving a survival benefit, I think, was just an issue of numbers. And here we have a combined analysis with a large number of patients and really convincing evidence that, at least with regard to exon 19 and 21, the so-called common mutations, that there clearly is a survival advantage. Now, interestingly, shown on this slide, is that survival advantage may not be uniform across these two mutations. You see to the left in the deletion 19 mutation, a very striking difference in overall survival of almost a year and a hazard ratio of 0.59, whereas to the right in the exon 21 L858R mutation, in fact, there was no survival advantage to the TKI, and if anything, chemotherapy did a little bit better. So this reminds us that not all EGFR mutations are created equal. Even the two most common mutations we see, exon 19 and 21, shown on this slide, have differential levels of sensitivity to EGFR TKI, and this is a very nice illustration. Now, fortunately, 90% of the EGFR mutations are either 19 or 21, but There are 10% of these patients have the so-called uncommon mutations, and many of those are resistance mutations. So you really need to read the fine print of your EGFR mutation report to be sure that you're dealing A, with a sensitizing mutation, and B, don't treat with a TKI those patients with known resistance mutations. So we'll pose two questions. Are EGFR TKIs standard first-line therapy for advanced non-small cell lung cancer with an EGFR mutations? Categorically, undeniably, yes. Do we need any more of these studies? No. I think 8 of them is good enough when we need to move on to other issues, which there are many in the EGFR mutant population. So let's move on to case challenge number 3 and talk about some emerging therapies. This case, 72-year-old man with a 50-pack year history of smoking, presents with hemoptysis and some shortness of breath. Chest radiograph reveals a left hilar mass and a left pleural effusion. CT scan confirms the hilar mass and effusion, also shows several liver metastases. His brain MRI is negative. You biopsy the liver and it shows a P40 positive squamous carcinoma patient. Now, squamous cell cancer, in my opinion, represents an unmet need. Many of the things we've talked about with regard to the actionable genotypes are, for all intents and purposes, seen only in the adenocarcinoma population. Platinum doublets remain the standard of care for these patients. As we've mentioned before, gem and taxane-based therapies are commonly used. Nab-paclitaxel has a greater response rate, but no PFS or overall survival benefit is known. Until recently, anti-angiogenic strategies were felt to be too toxic. However, ramucirumab does have some activity in squamous and appears to be safe. Pemetrexed is not an option. We do have some observations of EGFR monoclonal antibodies, both cetuximab and nesitubimab, leading to survival benefits. But I think it's fair to say that we need to get some new strategies for this rather large group of patients, about a third of the patients that we may see. Now, this slide looks at the response rates with regard to nab-paclitaxel relative to solvent-based paclitaxel, both in combination with carboplatin. This was a phase 3 trial that led to the approval of nab-paclitaxel plus carboplatin in non-small cell lung cancer. And you can see in the second column, the adenocarcinoma patients, there was really no difference in overall response rate, which was the primary endpoint of this phase 3 trial. But you can see in all the other subsets, particularly to the left in the squamous population, a difference of 24% response rate on solvent-based paclitaxel plus carbo and 41% on nab-paclitaxel plus carbo. And you see in the not otherwise specified in large cell variants that very similar advantages for nab-paclitaxel. The biologic basis of this is not clear. These were independently reviewed by radiologists. These were not investigator-assessed differences in response. These were blinded radiologists that made this assessment. So again, it's something to be aware of. This response rate in this trial did not translate into an overall survival benefit, but I would argue that what response does do is palliate symptoms. Most of our patients are symptomatic, so I think having a regimen with a higher response rate is of value to patients, particularly those that are symptomatic. Now, in my introduction to squamous, I mentioned nesitubimab. This is the design of the recent trial combining nesitubimab with cisplatin gemcitabine. Nesitubimab is the fully humanized cetuximab, so it's an anti-EGFR antibody. In this case, patients with advanced stage 4 squamous carcinoma, PS 0 to 2, were randomized to standard cisplatin gemcitabine versus the same chemotherapy with nesitubimab grafted on days 1 and 8. The primary endpoint was overall survival. This slide shows the primary outcome of overall survival. There was a survival advantage in favor of the nesitubimab arm, 11.5 months versus 9.9. The hazard ratio was 0.84, and you see the p-value of 0.012. Curves do separate within the first 2 to 4 months, and then they remain separate throughout 2 years. So clearly an advantage here. One of the issues is we would like to know who are those patients that are getting the advantage, and it raises the issues of biomarkers, which has been relatively elusive to date. This next slide shows the survival data I just showed you, but also shows the median PFS overall response in disease control rates. There was certainly a benefit in PFS that was modest. No significant difference in response, but a slight benefit in disease control rate as shown on this table. I previously mentioned ramucirumab. This is a monoclonal antibody directed at the vascular endothelial growth factor receptor 2. Remember, bevacizumab is directed to the VEGF ligand. This is an antibody to the VEGF receptor. Approved in December of 2014 for the treatment of metastatic non-small cell in the second line based on the REVEL trial. This slide shows the design of REVEL. These were second-line patients. You were to have received one prior regimen of platinum-based therapy. Maintenance was allowed. Prior Bev was allowed, and this was 0 to 1 with regard to performance status. Standard doses of second-line docetaxel, 75 milligrams per meter squared every 3 weeks, with placebo or with ramucirumab at 10 milligrams per kilogram every 3 weeks. Again, the primary endpoint was overall survival. This slide shows the intent to treat analysis with regard to overall survival, and a difference of about a month and a half, a hazard ratio of 0.857, and a p-value log rank of 0.02. Separation of the curves early and a modest difference that is persistent throughout the course of these curves. And so again, I think a step forward in our management of this patient, and certainly the first time that squamous patients would have an option of an anti-angiogenic. Now, we didn't show you the toxicity data. I think the toxicity data was pretty predictable based upon what we know about anti-VEGF antibodies like bevacizumab. However, in the squamous population, there were no safety concerns that were any different than the non-squamous population. So again, in the second line setting, squams do have an option in this particular time with ramucirumab. So I think this is an important observation for these patients. This slide shows the design of the master protocol in squamous lung cancer second line. I think this is really an important trial, and if you have the opportunity to enroll patients, I would highly encourage you. This is a long-standing effort between the NCI, the Thoracic Malignancy Steering Committee, the Food and Drug Administration, as well as the Friends of Cancer, and a number of our industry partners. The thing here is patients with squamous in the second line undergo the process of next-gen sequencing. Various targets are attempted to be identified. If you have a particular target, and you can see across the top, it's PIK3A kinase mutations, cell cycle aberrations, FGFR aberrations. Now, in this slide, the last arm of MET expression has been deleted. I won't go into that in detail, but this arm is no longer in existence. And if you have one of these targetable things, you're randomized to chemotherapy versus a targeted agent in this setting. So it really is a process of trying to get targeted therapy to targeted patients with the genetic alteration of interest. Again, in squamous, this is something that we really is vitally important to investigate in this setting. Now, obviously, not every patient is going to be a match for one of these targeted agents. And there is, as you notice in the upper right-hand side, a biomarker non-match group, and that's going to be a randomization between chemotherapy and an immunotherapeutic agent, actually a PD-L1 antibody in this setting. Now, that leads us to the new way of thinking about therapies, and that is leveraging the immune system. And this slide shows the complexity of the immune system, and tells us a little bit about how tumors may be immunosuppressive and hide from our immune system by using the programmed death receptor pathway. And understanding this pathway has created, as shown on this slide, a number of agents directed either at PD-1 or to the ligand of PD-1, PD-L1, and you can see nivolumab and pembrolizumab listed on the left-hand side. These are anti-PD-1 antibodies. And the anti-PD-L1, the Roche product MPDL32808 in the AstraZeneca Medi 4736 compound are directed at the ligand. Now, within the very recent time, March of this year, the FDA approved nivolumab, an anti-PD-1 agent, for the treatment of advanced squamous patients who had progressed after or on a platinum-based regimen. This actually was an FDA approval 3 months ahead of when they thought they were going to approve, and it was based upon the phase 3 Checkmate 017 trial that showed that nivolumab, relative to docetaxel, which is a perfectly reasonable standard, significantly improved overall response rate with a hazard ratio of 0.59. I think that's incredibly remarkable, that magnitude of difference. We've not seen in lung cancer with regard to survival outside the setting of an oncogenic driver situation, a hazard ratio like this. In fact, remember in the oncogenic driver situation, when we looked at the afatinib data, the hazard ratio for survival was 0.81. Here, for nivolumab, the hazard ratio is 0.59 and a p-value of 0.00025. The approval was supported also by data from the phase 2 Checkmate 063 trial that looked at the use of nivolumab in squamous histology patients in the third line and beyond. So this is not an isolated trial in this particular setting. And as we show on this next slide, certainly the slide says, what does this recent approval mean to clinical practice? I think this was going to have a huge impact on clinical practice. It's going to have a huge impact on clinical trials because many of the clinical trials in this setting use docetaxel as the control arm. And here we have an agent that is superior to docetaxel. So we have to kind of do some thinking. This next slide shows the initial phase 1 trial with nivolumab looking at various dose levels, in this case 1, 3, and 10 milligrams per kilogram every 2 weeks. This was phase 1 looking at safety and tolerability, but also activity in terms of secondary response rates. And we do have some mature data with regard to overall survival. And you see the best arm here seemed to be 3 milligrams per kilogram in this experience, looking at nearly a 50% 2-year overall survival rate. Now, again, this is a phase 1 trial, so there are a relatively small number of patients. They're highly selected patients that treated at typically academic centers. You see the response rates seem to be best at 3 milligrams per kilogram, about 24.3% of patients. So again, this is really incredible data, particularly once we get to the phase 3 data, as I just showed you before. Now, I mentioned the squamous phase 2 results, the Checkmate 063 trial. This was presented last fall in Chicago. And this is the summary of the data. 15% response rate, 40% disease control rate. The median time to response was about 3 months. 20% of patients were free of progression at 1 year. However, the median PFS was only 2 months. And so, again, this was squamous third line and beyond. So think about that population. That was a relatively, it is a relatively tough population to treat. They don't have a lot of great options. And here's a glimmer of hope. This data was supportive with regard to the nivolumab indication along with the phase 3 data we mentioned before. And here's the data. It replicated the phase 1 data. Again, median survival of 8.2 months, which, understanding this particular population, is rather encouraging. We have other agents. This is the Keynote 011 study exploring pembrolizumab in a number of different subsets. You see the number of different boxes noting either non-randomized or randomized experiences. Most of these patients are selected by PD-1L1 status, and various treatment schedules and doses are noted here. And I think to summarize this data, I'll direct you to this slide, which looks at a waterfall plot of a combination of all of these particular studies. And I think what the take-home message from this is that, again, like with the nivolumab story, pembrolizumab is an active agent. And we have many, many patients here in this waterfall plot that are showing reduction in target lesions. In fact, 58% of them had some reduction in target agents, and 21% of them met criteria for objective response rates overall. Again, a series of patients across a number of different studies that were summarized on the previous slide. The slide here looks at survival, and you can see that the survival looks quite encouraging. Again, this was a mix of patients. You see that patients that were treatment naive, as with everything, tend to do better than patients that had some form of previous treatment. Again, these are a reasonable number of patients, but also an early experience with this particular data, but encouraging that this immunotherapeutic approach is going to bring benefit to a number of different patients and patient settings. There are a number of ongoing clinical trials summarized on this particular slide, and we see that a number of them are phase 3. Some of them select patients by PD-L1 status. A couple of them are in first-line setting against standard chemotherapy, which I think is interesting. And so I think we're just at the beginning of this wave of immunotherapeutic approaches that is going to supplant perhaps chemotherapy in some situations, but also may be additive to chemotherapy. And so I think the future for our patients here is actually quite optimistic at this particular time with this new therapeutic approach in this setting. So I'll summarize with key takeaways from this discussion. Adequate tissue acquisition and management are paramount. One must, with a high level of confidence, establish the correct histologic and genotypic diagnosis. Histology and genotype drive our therapeutic options in this disease. Selected targeted agents have replaced chemotherapy as the standard of care in certain molecular subsets. We certainly talked in detail about EGFR mutations. We did not necessarily address ALK, but I believe it's the same as EGFR. Novel therapeutics, including immunotherapeutics, are being evaluated in clinical trials. And this is a very heterogeneous disease, and management of these patients has become very complex. Biomarkers play an important role in the management of this disease, and certainly we need to reinforce with all of our colleagues the concept of adequate tissue acquisition and handling the tissue appropriately at the time of diagnosis to get these things done. So I want to thank you for participating in this activity of case-based challenges, histology, molecular testing, and treatment decisions in non-small cell lung cancer. The enduring activities include a downloadable slide deck and accompanying speaker notes for use as a self-study resource to assist in reinforcing key leaning points. There are a number of enduring activities here, downloadable slide deck and accompanying speaker notes for use as a self-study resource to assist in reinforcing key learning points from this live activity, or for you to incorporate into additional staff education. And then a virtual grand rounds hosted by Real CME. A virtual grand rounds is a continuing education meeting in an online format. Please text NSCLC in the subject line to 90776. You will be provided a link in which to access and download these supplemental educational resources. Thank you very much.